I'm sure throughout the day we've all heard a lot about social determinants of health. I hope in this session what I can do is tie it more specifically to our heart failure patients. And what are some of the things that we put into a treatment plan that we may never assess is that patient and family caregiver actually going to be able to do what they're sitting in the bed saying to you, yes, yes, and yes. How many of you treat heart failure patients? Really? Oh, a few hands going up. Okay, how many of you are at the acute care level, the hospital level? And how many of you at the ambulatory side? So here's a question for you. In the last 12 months, of the heart failure patients that you have worked with, how many of them were readmitted within 30 days? If you've had a patient readmitted, just raise your hand. You don't have to tell me how many. And then how many were readmitted within 6 months after being discharged? And that's a standard statistic that we see. And so the question is, did you believe when you saw that patient in the hospital, you put the treatment regime together, you actually talked to the patient and their family caregiver was there, and they agreed to all of this, that you'd done your job, and this patient was going to be able to maintain whether in a skilled nursing facility or whether at home. And yet, they ended up back in the hospital. So why? What is it that we missed or that we didn't see in putting this plan together? So today, I want to talk a little bit about what are some of those gaps and barriers, what are some of the things that we can do, and then how does that tie together if we do an assessment of social determinants of health. Now today I learned something new in one of the sessions. Reverend Hickman said a very interesting thing as they were moving into the community and doing assessments for their population. She said, I don't like using social determinants because determinant means you've made up your mind. She said, I prefer to talk about the social influencers of health. And as I listened to that, I thought that makes so much more sense. Because those influencers may not be just what you're seeing of the patient that's sitting in front of you today, or even assessing where they are today. Some of those influencers could go all the way back to what? Infancy, childhood, schools, all the things that they experienced while they were growing up. So I think that we need to look at this in a broader context. From the standpoint of heart failure, we know that we have a large contingency of our population that have heart failure. How many of you only see a patient with heart failure and there's no other diagnosis? Complicates the situation, right? A lot of the patients that I'm familiar with have heart failure. They may also have atrial fib. They've got some kidney dysfunction. They have diabetes. They probably are obese. They're hypertensive. And the list goes on and on and on. But of that, we know where we stand today. The question that I always ask myself, are we making enough difference that we're going to reduce that, or are we going to continue to see that number grow? And what do you all think? That number's going to grow. The generations that we're looking at below us are more unhealthy than probably us sitting in this room. And each generation is experiencing that to a different degree. So I think that we really need to understand, if we put the right clinical plan together, what else do we need to do to improve for this population? National average, 24% of these patients will be readmitted within that 30 days, and over 50% within 6 months. The experience of a heart failure patient, too, is multiple. Depending on the stage that they're in, it can be within their primary care, their cardiologist, maybe a cardiac rehab. But as those stages progress, there are more and more providers that are involved in that, and therefore increases what? The risk that information doesn't get transferred, the risk that medication management will have issues that we need to deal with, the communication not only between the providers, but between the patient and the family caregiver, and against all other odds to other family members that may be involved in this. And a lot of our experience shows that the patient sitting at that moment of discharge, who's sitting in front of you with that treatment plan, is saying what to everything you ask them? Yes, yes, yes. Why? Because their eye is on that door. There are very few patients or consumers that want to stay in the hospital. Yes, we have a percentage, but most of them want to be out of that hospital and want to be in the home environment. So they stand a higher risk as they progress through their disease to have miscommunications, medication errors, lack of information being transferred, and really a true understanding of the disease they're dealing with and how they can be more involved in this whole process. The continuum of care is significant today, and we all know that, and yet that communication really becomes more and more difficult. There was, in another session I was in, that unfortunately care today is still provided in silos, but patients don't get well in silos. And that quote was from a patient that was involved in talking about our healthcare system. As we look at this, we say, okay, well, how can we help? I'm going to say this right up front. We can support, but we have to engage that patient and family caregiver. They are the only common denominator that happens through transitions in care coordination. The hospitalist isn't going to follow them to the skilled nursing facility, isn't going to follow them to home. The case manager in the hospital is not going to follow them long-term to home or to a skilled nursing facility or even to palliative care. We all do a tremendous amount of assessment, treatment planning, creating these options for patients, and yet transferring those continue to be the issue and the problem. So what is it that we really need to look at? Well, NTalk at, 10 years ago now, developed what they called the 7 essential elements of a good transitions. And what we find is these 7 elements are going to be within your systems probably now. You're looking at them and we're working on them. Are they all working together? And the answer is no, but there are a lot of things that we can do. And they involve medication management. How many of you have that down pat? Medication reconciliation and management and care coordination to the next level of care. How many of you have it down pat when the patient comes in the hospital? Do you ever ask that patient, can you tell me what medications that you're on, whether you're inpatient or outpatient? I'll bet you get 4 options. One of the biggest ones is for the patient to say what? I'm on a blue pill in the morning, a white pill in the afternoon, and a yellow pill 3 times a day. The next is to give you a bag of medications and say, well, these are my medications. And as I've heard from doctors and from nurses and case managers, not only are the patient's medications in there, but Aunt Tilly's medications in there because she's sharing with the patient. It helped. In several cases, doctors have told me, oh yes, and the pet's medications are in there too because we're managing all medications for the family. And that 4th option is they just don't know. On top of that, oftentimes when we're doing this, we're looking at time here and now. We never ask what's in the medicine cabinet at home. We don't ask what they're buying through the mail. If we live close to either the Canadian border or the Mexican border, how many of us ask, are you crossing over the border and buying in the various pharmacies? And let me tell you, sometimes that is not geared because we're not prescribing, it's geared because of a financial burden on what they have to pay for it here in the United States. Same drug in Mexico under the same pharmaceutical company is about almost 1/4 to 25 to 55% less. Why do I know that? 1989, I'm working at Nogales, Arizona. I have 3 boys. All 3 boys have asthma. All 3 boys are on medication and inhalers. What does an inhaler cost in the United States? If you don't have insurance, well, back then, it was $20 to $25. I went across the border, same sharing inhaler, $2.50. 4 boys. Where are you going to go? So those are the things that when we look at medication reconciliation, we don't often pull in together. And the last thing I'm going to tell you today, because it's really important, is make sure you ask them. Are you taking and self-medicating for pain? Are you taking street drugs? Are you smoking medical marijuana or recreational marijuana or both? Because it all plays in to where we go for medication management. Transition planning. We say we have a great transition plan, and yet did we really assess for social influencers of health or their special needs? In many cases, no. When we have transition planning, did we really include the patient and the family caregiver, or did we come up with that as a team and say, this is a great plan? To take it to the patient and say, do you agree? is not patient engagement, it's not shared decision making, and it definitely does not get the commitment from the patient and the family caregiver. When we look at healthcare provider engagement, that needs to happen long before we start working with our patients, because these need to be care teams where we have really sat down and the doctor looking at the nurse looking at the social worker looking at the pharmacist, and we've sat down as a full team, whether a transition nurse, a care manager, a case manager, a social worker, and we said, here's our role and scope. How do we do this together? How can we take things off that the physician feels that he doesn't have time for and in many cases wasn't trained for? Those of you that are physicians out there, were you trained for motivational interviewing? Were you really trained to sit down and assess those social determinants of health and connect them with the community? No. But when we started speaking with CMS, which was about 2.5 years ago, about social determinants of health, guess where they wanted to place that assessment? To the physician. And we said, that doesn't make sense. You have a care team. And that care team needs to do that to get that provider engagement. Follow-up care, did we put it together, especially for our heart failure patients in their next visits, any consultations, any tests that need to be followed up on? Did we transfer all information to that next level of care, and did the family and the patient understand that information? And do we have accountability across? So let's talk about it for the heart failure patient with medications. The medications that we've been talking about are often things that I don't need to talk to. They're in your care plans, they're in the critical guidelines from the ACA, but they are complex regimes. And they're not enough for us as a care team to talk about it. The patient needs to understand it. Will they understand it in the same language that we talk about it as clinicians? Probably not. My mother is a heart failure patient. My mother is 95 years old. No matter how hard I try, if my mother would be alone, it would be I take a yellow pill, a blue pill, I take one that looks like a football. That's what she would say. When it comes to multiple prescribers, that sharing of information for this particular population that we're talking about is really important. How many of you, when you got down to really looking at medications after the patient has been diagnosed with heart failure for maybe 2 to 5 years, have found that there are 2 and 3 of the same medications because of the prescribers added and not communicated? There needs to be a patient-centric medication list. Now, what do I mean by that? Well, I'm going to tell you there's no one answer, because a patient-centered medication list for my 27-year-old grandson looks very different than it does for my 95-year-old mother. What's the difference? Well, my grandson is in an app, and it's all maintained, and he sends it off, and by the way, he could care less about HIPAA. It goes wherever he wants to send it. He can send it any place he would like. My mother, who is also legally blind and wears hearing aids and is quite frail, none of it makes any sense. She needs someone to manage that for her, and that's what we do. The kids that are in between, which are our grown children, which are from 39 to 50, are at all stages of how they see their medication list. So when people tell me, oh yeah, we have it in the EMR, we do it, we print it, and we give it to the patient, I always want to say, how old is that patient? How old is that family caregiver? Is that of use to the patient that you are giving it to? Are they able to take it and use it? Or is it something they just take home with all the other papers and lay it down on the table? Which used to happen to my mother. No matter how many times it was written in her record, she is legally blind. She has macular. She cannot see in the centers. What would they give her when she was discharged? Papers. So what does that mean, and how do we do that? For heart failure patients, it is really a necessity to understand, are we delivering it in a format that the patient and the family caregiver can use and that it has meaning to them? And then it must be communicated, the education about those medications, how to maintain that list, how to share that list, and what to do with it. And it should be confirmed at that next site. If we do that, we begin to close some of these loopholes of where we don't transition the information appropriately. So what happens with transition planning? Well, the transition planning is what we're supposed to be doing as a care team with the patient and the family caregiver. I don't know how many patients tell me, well, I don't know. They gave me a piece of paper. They said, this is what I was supposed to do. This is when my next appointment is. This is where I was supposed to go. No discussion, no real understanding of why they needed to do that. And I want us to kind of keep in mind that we're talking here about diet and medications. Remember that as I talk to you about social influencers. We're talking about transportation to be able to get to visits. Remember that as we talk about that. We're talking about health literacy, and I want to expand that. There's a difference between health literacy in our language, food literacy, when we're talking about diets for special patients like heart failure patients, and the difference between an education level and your primary language. How many of you work with Hispanic patients? How many of you speak Spanish? A few of you. How many of you often wonder, do they really understand both the written word and the saying? It's very difficult to just be able to assume that patients understand. Do you all know what assume means? And that's exactly why I ask people, please don't assume anything. Talk to your patient and your family caregiver and make sure that there's an understanding. I love it when the nurse or the doctor or the pharmacist says, do you understand what we want you to do at home? What do you get? Yes. What would happen if you asked, do you feel confident that you're going to be able to do what we're asking you to do at home? You may still get some yeses, but on top of that, then you would say, repeat back to me what that treatment plan is. Because you need to confirm these things when you're doing this transition planning. Now, how many of you would say, we do great transition planning? How many of you send it to that next level of care? How many of you know it got to the next level of care? So let me tell you about an experience. My mother was in the hospital just about 4 months ago, atrial fib on top of all of the other issues she's dealing with, and it was time to transfer her to a rehab in long-term care. They did the transportation, the hospital did. I got to the skilled and the rehab center probably about 3 hours after my mother had gotten there. And I could see the nurses, they were talking about her, and they were trying to figure out things. And the minute I heard, well, where's the medication list? I'm like, okay, why didn't that come with him? I found the record and the medication list. Now, where do you think I found it? In the bag with her clothes, with the wash basin, with the Kleenex, and with everything else. That's how it was sent via the ambulance over to the long-term care. But did anybody give it to them? No. Now, when do you think she got transferred? Friday night, 5 o'clock, arrived there at 6 o'clock. If we hadn't found that, where would they be over the weekend? I know you've all lived through that. You can't get hold of what you need. You're not sure of the medications. We have a patient that is sitting, a resident now sitting, what? 48 hours waiting for things to be connect. So you can do the best transition possible, but if you don't know that it got there, that you transitioned it, they got it, and they can understand it, you're still having these issues. And these are some of the critical issues for heart failure patients where they fall through the cracks. Family and patient education. I have to tell you that in the senior generation, I'll bet you've all been there, how many times does the patient look at you with a blank stare when you say they have heart failure? They're sitting in bed, they're breathing fine now, they're feeling pretty good, their heart's beating fine. What do you mean, I have heart failure? So to describe that is not good enough to give them a piece of paper. That education is supposed to be to empower patients, to engage them with us, and to have them work, to understand what it is to do self-care, to understand how important this is for the progression of the illness. I often say this about diabetics. If you've been a diabetic between 5 and 10 years, you think, I know it all, I got it. I can tell you that when you get them in under a hospitalization and you start talking to them about their diabetes, they don't know it all, they haven't got it all together. This is another population where this is really important for us to look at. Provide the opportunity for education. If we have them in the hospital even for 48 hours. Is there at least 30 minutes in the time where we can sit down and talk with them so that when they go to that next level of care, we can follow up? Are we giving written instructions to people who can't see? If that's the case, can we do an audio? Are we able to have the caregiver there that can help us with that patient to really understand that, especially if that patient is going to go back to independent living? Are we able to understand what it is they're dealing with when they go home? And are we able to understand that there could be a conflict between the patient and the family caregiver? How many of you have had that senior, a frail senior, who wants to live independent, is on a walker constantly, has probably had 2 or 3 falls, paramedics have come out to see them, does have vision problems and hearing problems. We know they should be in assisted living or some other type of help, and what do they tell you? I'm going to go home. It's up to us to help that family caregiver, to help that patient realize what they're dealing with when they make those decisions. And I'm very well familiar with that. My mother took 7 falls over 3 weeks because I couldn't get her to accept to go into assisted living. And here's the problem. Her body may be frail. She may have multiple comorbidities, but her mind is as active and as acute as can be. And you don't take that away from them. She gave me the power of attorney, but to implement that would really mean a real break in our relationship. So I used the hospital staff, even though I knew beyond a shadow of a doubt where she needed to go, to really help me convince her. I understood, they understood, and we were able to make that decision. So these things are not always about we're going to get them so they can go home. We're going to put them and help them achieve what is really safe for a quality of life. And yes, she had the paramedics come in 3 times. And you know what she said to me? They are the cutest guys I have ever seen. I said, Mother, you can't even see that well. Oh, I can see that, she says. So, education, not only for the patient, but the caregiver and those that are around them is extremely important, especially with our heart failure patients, that they understand their illness. They understand it's going to progress, but they understand that we can help slow that progression, that they understand the importance not only of their medications, but of their diet, of their hypertensive medicine, and what that is really going to mean long term. To do that, I put this up here just so that we can see. If patients get education prior to hospital discharge, it really impacts the outcome. There is a study that they did, and you can see the line which is red, those that received the education and those that did not. And the key things they looked at in that education was lifestyle, as you can see up there, their diet, their activity, and education about that, their medications, follow-up appointments, their self-evaluation, their rescue plan, what do I do when I get into trouble, and their discharge instructions. And I want you to remember those key points, because as I start to talk about social determinants of health, there's going to be some key things there. For us, information transfer is key to that next level of care. Please don't send it unless you know it can be received and they can talk to you. To us, that's bilateral directional communication. It isn't just enough to send it. It's like the quarterback that I watched in these playoff games that couldn't find anybody, so he just threw the ball out there, hoping it would either go someplace or go out of bounds. We can't be responsible for that. We have to make sure that this information gets to that next level of care. We're connecting with electronic medical records. The one thing that I have always been aware of is an electronic medical record was never developed years ago to do care coordination. It was developed to bill. And in this that we're developing, sometimes we inherit a system that you look at and you go, who in the world thought of this one? How many clicks do I have to do to get this to move on? How many databases do I have to double entry in to make sure that I can get it there? So I'm going to tell you this. This is from my heart as a clinician. It isn't an ask for me anymore. It's a demand that these systems think and work for us, and that we're not trying to figure out how it was kludged together so that we couldn't do the things that we need to do. And that includes the fact that patients need portals into this and can communicate with us. If we're going to do this 24/7, let's get this down pat. I'm pretty strong when I'm talking to tech people saying, no, don't tell me this is the fix. I need it to work, and I need it to work so it's in my work frame. And it works with my doctor, it works with my social worker that I'm talking to, and I'm able to take care of this. Follow-up care for our heart failure patients. Timely transfer of information and follow-up care is absolutely necessary. Some of these are very critical in that we don't allow 48, 72, 96 hours to go by, that we communicate how important that is, and that patients, before they leave the acute care or go into the post-acute, also are able to know that they're going to see a provider and where they need to go. And I'm going to talk a little bit about what happened in one of the hospitals. And then engagement and shared accountability. These are really important. Was that 5 or 10, Gina? 10, good. You looked at 5, I was like, woohoo. So let's talk a little bit about social determinants of health for heart failure patients. Those populations are very needy in needing to understand because they have complex needs. 40% of individual healthcare outcomes can be related to these influencers. And compared, as we've learned, to other countries, we are very low on the totem pole for what we put into these social needs. And individuals without these needs will have more ER visits, will have more hospital readmissions, and will have poor dietary needs that aren't met. And so these are things that affect our heart failure population pretty significantly. If we look at the barriers to successful self-care, a lot of them are based in the things that we're talking about between not only the comorbidities, but the education and the literacy to understand that. And I believe that there is a way to communicate that with any individual, even patients today who don't read. Anybody have patients that don't read? We do. We have patients that never went further than the 6th grade or the 8th grade and never got that chance. And so we need to learn how to be able to do that. Those social determinants and those social norms are not only what we are today, but what we were as we were growing up, and the neighborhood and the environment that we work in and live in contribute to that. So this is from Kaiser, and it is a breakdown of social determinants of health. So, how many of you tell your heart failure patients they need to get out and exercise? Come on, everybody share. I know you do. How many of you tell your patients there's a diet that you need to follow, especially if they're extremely hypertensive? How many of you ask them where they live and do they have sidewalks in their neighborhood? A few of you. We live in a community called Dewey Humboldt, Arizona. Anybody know where that is? A couple of you. Population, 4,067. Maybe 2% of that neighborhood has sidewalks. It's a very rural area. It's a ranching area, it's a cattle area, it's an agricultural area. So asking people to get out and walk is not always the easiest thing to do. Now, 7 miles down the road is Prescott Valley. There's 47,000 people there. 7 more miles down the road is Prescott. That's 45,000. And then Chino Valley has 11,000. So we're about 106,000 in this 45-mile radius. But very few can raise their hand and say, well, I do have sidewalks. I've got a playground. I've got things I can do to exercise. So we need to understand that, because if you're going to tell them to exercise, it's got to be a safe place. For those of you that are in urban and metro cities, how many of you ask them how safe their neighborhood and their environment is? How many of you ask them, do you have gangs in your neighborhood? Do you feel safe to walk down the street? I love the one that told me a few months ago, oh yes, as long as I'm walking between 9 and 3 during the day. So that meant there were a lot of things going on, but we hadn't really picked that up. We talk about food insecurity. We talk about asking patients about, do you have enough food through the month? If you buy food at the beginning of the month, does it last you all month long? It isn't about are you hungry, it's about the food and the type of food that you have. You have a heart failure diet that you're supposed to follow, which means that that's more healthy food, wholesome food, than you would just get from just going and picking up frozen foods, quick foods, eating at Burger King, eating at McDonald's, and pizza. And yet many times those are the things that we look at. So it's really important to understand that. I also put up Healthy People 2020 for you on the slides because this breaks it down by the various areas, from your environment to your clinical issues, to the social issues, to your financial issues, to your education level, your health literacy, all the things that are going to be concerned. Now, how many of you are thinking, my gosh, I don't have time to do an assessment like that? We don't. But there are ways to be able to do this. Looking at the health literacy is making sure that we can speak that language and understand. If there were 3 things that a patient should ask, what should it be? Ask me 3 is great. What is my main problem? What do I need to do? And what's important for me to do this? Should you be looking at patients and looking at social influencers when they come into the ER? Yes. How about if they're admitted for observation? Yes. Acute care in the hospital? Yes. Post-acute going home. Primary care new patients. Entering into new systems. But you don't have to reinvent the wheel. I tell people if there are only 5 things that you have time to ask in the ER, maybe in observation: food, housing, transportation, utilities, safety. Those 5 things. 2 of these, the one on the left that is from the family physicians, is 12 questions. Easy to use, you can adapt it. The other from CMS, much longer, 26 questions. But they help us dive down into these issues and try and resolve these problems. How many of you feel, geez, if I ask that and I get the assessment, I got to do something with it? How many of you know your lawyers are going to say that? You ask the question, you got to do something with it. That's why before you start these programs, create those networks with your community. Look at it across the board for where you are. And I very much want to say, if you're in a rural area, we don't have all the services that we've seen or heard in many of these metro and urban areas. So how do we do this? Those in a rural area, have you ever thought about contracting with your paramedics? They can do a drop-in to a home and check on a patient for you. Dewey-Humboldt doesn't have Lyft or Uber or buses. So what do you do? Well, there are private areas that we can contract with within our church, within school systems, within various aspects. So to look at it, how do we tie these together across the board? And then when we've assessed this and we have these in place, we know we have these problems, this is how we're going to resolve it. Sit down with your patients as you're going through this and do some shared decision making. Everybody says, well, that takes too long. If you have a real issue that there is no transportation, there's no food, I guarantee you your heart failure patient will be back in the hospital within 30 days. So that few minutes you spend putting this together will really tie it together. It's a complicated system, and the way we go through it, we really have to be able to tie these things and communicate. If we don't, we continue to do this in silos, and patients continue to fall through it. And it is really hurtful to all of us when a patient tells us that they had the best intentions in the world, and these are the things that affected why they couldn't get that done. I want to leave you with this. I'm going to go through this really quickly because I feel it's important. You cannot just do this and not evaluate it, because the evaluation is what tells us, are we doing the right things to improve it? An evaluation is more than just a quality improvement, because you're really digging down into what am I doing to improve these issues that I have. So we look at it more rigorous than a QI process, but we also involve a collective effort of stakeholders to help us pull this together and use a measurement chart. Now, this does not have to be all fully tested as much as I'm going to evaluate because I'm making changes and I'm putting these pieces together. NTalk put together a web-based tool. It's on our website. Everything on our website in our educational format is free to the industry. We do not charge for it. In fact, anything you find on our website outside of our software is not even copyrighted, because we just want people to use it. The only reason we copyrighted this is because we don't charge for it, and we didn't want somebody to take it and start to charge for it. But we actually created, through this, we have a pathway called for heart failure. It's in our Knowledge and Resource Center, and it's built into the software that you can actually track. Am I improving this for my heart failure patients by the pieces that I'm putting together? Why is that important? Well, because today, it isn't just about telling the stories, it's about proving those stories and that you've had the impact. So I encourage you, if you don't have a system that does this, look at this. It's a simple system, and unfortunately there is some double data entry, but you can pick and choose to track one individual intervention. How many of you are trying to track 5 interventions at the same time and figure out which one is giving you the biggest return? That makes it really difficult. Pick an intervention, track it for 30, 60, 90 days, and then you can add the next one in to be able to track it. Because until we know what we're really dealing with, we keep throwing everything at the wall to see if that's what it is. It focuses on transition, and it's a no-cost tool, so please feel free to use it. What are the winning strategies we're talking about for heart failure patients? Folks, focus on patient-centered care. Where is that patient? What do I need to do? Continuous quality improvement across the board and effective team practice. No one individual can ever be responsible for this. There's so many stories that I could tell you along this line, but we really need to be able to work through. Look at it, look at it from the standpoint of a commitment to the data analytics that you have, and make your decisions from your data, conversations with your team, and conversations with your patients. That combination helps you put this together. Be culturally sensitive to the issues and needs and to these social influencers. I'm actually going to take that determinants off of all my slides and use that influencers because I like that better. And use a population health focus and team leadership and communication. And that last one, never assume. Always assess, communicate, communicate, and communicate. Because if you don't do that, then you miss the opportunity. From that particular standpoint, I think we can make a difference. And I think that we have organizations that are showing that. But it's the combination of everything. And rather than being overwhelmed about it, rather than thinking I got to develop all these assessments, use some of these resources, pull them together and adapt them to your own system. Because that makes our job a collaborative team effort and not just sitting out there by ourselves. And I think that that is really important. Now, some of you that know me will have heard this, but I can't leave you without this because I believe communication is so important. Bubba goes in to the medical clinic, and the receptionist says, "Bubba, what are you here for?" He says, "Shingles." She says, "Have a seat, and I'll be with you in just a few minutes, and we'll bring you back." When they go back to the nurse says, "Bubba, what are you here for?" He says, "Shingles." She said, "I want to get your blood pressure, your weight, we're going to do a urinalysis, and then you're going to go into the exam room, take your clothes off, put the gown on, the doctor will be in shortly." Bubba does that. The doctor comes in about a half hour. Of course, Bubba being Bubba, he didn't put the gown on. The doctor says, "Bubba, what are you here for?" He says, "Shingles." She looks at him, and she says, "Where?" He says, "They're out on the truck, Doc. Where do you want me to put them?" I bet you if you don't remember anything of my speech, you're going to remember this joke. But the key is, they both communicated, and they both thought they were saying the same thing, but they couldn't have been on different planes. Remember that. You remember that every day you talk to your teenagers. For those of us that have adult children, I still remember that because I still can't sometimes get on that same plane. But to do that is to communicate, to communicate, to communicate, and to listen. Thank you.